Hello everyone, welcome back to the channel. Today we are kicking off a brand new series focused on orthopedics and rheumatology, two high yield subjects for AMC Part 1 that frequently shows up in recall questions as well as in the exam. So in this series I'll break down the most exam relevant topics. Each episode will cover 5 to 6 key conditions with clinical highlights, diagnosis and the management based on the Australian guidelines. I'll keep it clear, concise and recall oriented so you get exactly what you need to know for the AMC exam. In this video, the topics I'll be covering are acute compartment syndrome, ankylosing spondylitis, vasculitis, clavicular fracture and Dupuytren's contracture. So first topic is acute compartment syndrome. The only thing that you need to know about it is what basically is happening in acute compartment syndrome is there is a surgical emergency where increased pressure within the closed fascial compartment compromises the circulation and tissue function. So there is no blood supply to the respected organ. And there could be multiple reasons for it. One is fractures, the other one is tight cast or dressing. Crush injuries could be another reason, and burns also. So most important thing about this topic in AMC, 6 P's. So 6 P's would be, one is pain, paresthesis, pallor, paralysis, pulselessness and poikilothermia. So these features you'll be able to see in the exam stem and then you'll be able to make the diagnosis for it. Now there is a important point that pulses may be present early. So do not rule out acute compartment syndrome based on the presence of pulses. Okay, now coming to the diagnosis. It is a clinical diagnosis. If you are uncertain about it, then you have to measure the compartment pressure and it would be more than 30 mmHg. Next is, the important thing is about the management. So treatment for acute compartment syndrome is immediate fasciotomy, which is basically the removal of tight dressing or cast, and you have to keep the limb at heart level, not elevated. Now, the two most common compartment syndromes that are occurring is, one is in the lower leg and the other one is forearm compartment syndrome. That is because of distal radial fractures. Now, the complication for acute compartment syndrome, the important complication that we need to make sure doesn't occur is Volkmann's ischemic contractures. It is basically a permanent shortening of the forearm muscles, resulting in a claw-like deformity of the finger, hand and wrist. Next topic is ankylosing spondylitis. It is a chronic seronegative spondyloarthropathy and it primarily affects the axial skeleton, that is the sacroiliac joints and the spine. So for the diagnosis, you will have to see in the question stem there are few features. One is chronic back pain should be there for more than 3 months with the age of less than 45 years. Next step would be to check on any sort of imaging. It could be MRI, it could be X-ray, but X-ray is preferred one and we'll be seeing the sacroiliitis. And then the other thing is we'll have to check for HLA-27 positivity and other conditions associated with it. First is psoriatic arthritis. The next one is ankylosing spondylitis. Then we have inflammatory bowel diseases. And the last one is reactive arthritis, also known as Ritter syndrome. Other manifestations with ankylosing spondylitis could be like inflammatory back pain, it could be uveitis, it could be dactylitis, it could be psoriasis, or it could be inflammatory bowel disease. Now, when we are checking for the CBC report, the ESR and CRP would be elevated, and in the X-ray, the important findings are sacroiliitis as an early finding and bamboo spine as a late finding. Now, when we are talking about the management for ankylosing spondylitis, so first line is NSAIDs. We'll have to prescribe simple NSAIDs or like indomethacin, naproxen we can give. Along with that, we'll have to do physiotherapy and posture exercises. If there is inadequate response to NSAIDs and physiotherapy, the next step would be to prescribe the patient anti-TNF agents like etanercept or adalimumab. So these are the treatment policies that we are following for ankylosing spondylitis, and along with that supportive therapies is given like regular physical therapy or smoking cessation would be appreciated, and if there is osteoporosis then give treatment according to that. You'll have to avoid steroids and opioid for long term in these patients. So AMC exam tip would be for the diagnosis of ankylosing spondylitis is young man with a lower back pain and morning stiffness. You have to always suspect ankylosing spondylitis in this patient. An X-ray would be showing sacroiliitis and bamboo spine. This will confirm the diagnosis. Next topic is vasculitis. Although this topic is very huge, but then I'll only tell you the most important findings that AMC is asking in the exam. So we'll start off with large vessel vasculitis. There are only two important diseases that we have to make sure we remember. One is giant cell arteritis and the other one is Takayasu arteritis. So in giant cell arteritis, the important thing is females are more affected and the age should be more than 50 years. Now the important feature would be unilateral headache, along with that jaw claudication should be there, and temporal artery tenderness should be there. Now what are the features that you need to look in the question stem so as to make the diagnosis of giant cell arteritis is the ESR and CRP would be very much elevated, and there is a high yield association of this disease with polymyalgia rheumatica. So we'll need to make sure that we are giving corticosteroids prior to doing biopsy of the temporal artery, because there is a high risk of blindness due to anterior ischemic optic neuropathy. That's it for giant cell arteritis. Then next is Takayasu arteritis. The only thing that you need to know is it is also known as a pulseless disease, and the artery that is affected is subclavian, left subclavian, and the basic thing that is occurring in this disease is narrowing of the aortic arch. ESR would be elevated and the treatment is corticosteroids. Same. Next is medium vessel vasculitis. There are three conditions in this section. First is Burgess disease, also known as thromboangiitis obliterans. The only thing that you have to remember is smoking cessation as the treatment for it. I'll not go in detail of this disease. The only treatment that you need to make sure is smoking cessation we have to do. Now, next is Kawasaki disease. There is a mnemonic for it. The mnemonic is crash. So, C is conjunctivitis, R is rash, A is adenopathy, mostly cervical, S is strawberry tongue, and then we have H, that is hand and foot changes like edema and erythema. And along with that, fever has to be there for more than 5 days. Now, the most important complication that we have to associate with Kawasaki disease is coronary artery aneurysms and thrombosis or rupture. It is the most important cause for death of the patient also. For the treatment, AMC asked this. The treatment is high dose aspirin with IV immunoglobulins is the treatment for it. Next is polyarteritis nodosa. The only thing that you have to remember in polyarteritis nodosa is it is Australian antigen positive, that is hepatitis B, seropositivity is there. Next is no lung involvement would be there, only renal and visceral arteries would be affected. The next is string of pearls appearance would be visible, and for the treatment corticosteroids and cyclophosphamide we are giving. That's it. And for the investigation for polyarteritis nodosa, we are doing angiogram or biopsy. Next section is small vessels. So there are 4 diseases in it that are most important that AMC asked. First is microscopic polyangiitis. The only thing is renal and pulmonary vessels would be affected. It would be MPO positive and PNK positive, and the treatment for it is prednisolone or cyclophosphamide. That's it. Second is granulomatous with polyangiitis, also known as Wegener's disease. So for this, there you have to know that there are ENT involvement, lung involvement, and kidney involvement. ENT is upper respiratory tract infections would be there, and it is associated with CNK. And the treatment is similar to microscopic polyangiitis, that is prednisolone or cyclophosphamide. Next is Churg-Strauss disease or eosinophilic granulomatous with polyangiitis. Now in this disease, you have to make sure that eosinophilic involvement should be there. There has to be a history of asthma or ongoing asthma, and neuropathy would be seen. PNK would be positive and the treatment would be corticosteroids. And the last one is IgA vasculitis, also known as Hinox-Nolan purpura. There is a triad for it that is important. There has to be palpable purpura with abdominal pain. Next is renal involvement should be there, and the next is arthritis should be there. The important thing for the treatment, we have to make sure that supportive treatment is given as the initial thing and then corticosteroids afterwards. And it has association with intussusception or IgA nephropathy. Now this 3 and the last disease is Behçet's syndrome. So basically there are recurrent oral or genital ulcers would be there. Along with that, uveitis and erythema nodosum would be there. It is triggered by HSV and parvovirus. and mostly it is associated with HLA-B51. These features you have to remember in order to complete vasculitis, and mostly they are asking questions about the important words that I have told you in this section. Just make sure that you able to catch those phrases in the question stem, and then you will be sorted for vasculitis. Next is clavicular fracture. The most common site would be middle third of the clavicle, and 80% of the cases it is occurring in the same site. Next is mechanism of action. It would be fall on outstretched hand or shoulder, or it could be direct trauma to the clavicle, which can occur in sports injury or motorbike accidents. Clinical features would be very evident, like shoulder pain and swelling. Visible deformity would be there, also known as step-off deformity, and the patient will support arm with the opposite hand, and crepitus on palpation would be there. Now you have to check for two things. One is neurovascular compromise and the other is skin tenting or open fracture. For the diagnosis, first the initial thing you have to do is X-ray of the clavicle in an AP view with 15-degree cephalic tilt view, and you'll look for the displacement or the shortening, and then you have to rule out pneumothorax as it is a severe complication of clavicular fracture. For the treatment, there are two different treatment choices that we have. One is non-operative and the other one is surgical referral. So for non-operative, we are using a figure of 8 sling or a simple broad arm sling for the patient, and for the pain, we'll just give analgesics to the patient, and early shoulder mobilization program should be started after 1 to 2 weeks. For the surgical referral, the indications are if there is an open fracture or neurovascular injury is there or skin tenting is there, non-union or symptomatic malunion is there. Complications are malunion is the most common complication and brachial plexus injury is another complication. For the treatment, I have already told you, if the patient is stable, then arm sling for 4 to 6 weeks, and if the patient is unstable, then open reduction internal fixation is what we are doing to prevent non-union. So AMC exam tip is you have to choose more conservative options as the initial management, like sling and analgesics, unless there is an open fracture or skin tenting or displacement is there. Then you have to go for orthopedic referral or surgical fixation. Last topic is Dupuytren contracture. It is a fibrosing disorder of the palmar fascia, which can lead to a progressive flexion contraction of the fingers. Mostly the fingers that are affected are the lateral ones, that is 4th and 5th finger. There would be skin puckering. It is the earliest sign. For the etiology, 70% of the cases are because of genetic predisposition. Other than that, ischemic injury to the palmar fascia should be considered, and alcohol abuse is the most common cause. You'll have to see in the question stem if there is a mention of alcohol, chronic alcohol intake, then you have to make sure that you rule out Dupuytren contracture in the patient. And another important investigation that you have to make sure that you are doing is blood glucose level check. For the initial investigation, most important investigation must be done before surgery. If these three things they are asking, then you have to do is ultrasound. You have to make sure that you rule out differential diagnosis like palmar fasciitis, claw hand or deformity, or stenosing tenosynovitis. For the treatment, if the patient is at mild or early stage, then observation and hand therapy we can do. If the disease is progressing or functional impairment is there, then you have to refer the patient to a hand surgeon, or fasciotomy is the treatment of choice, that is the surgical release. Or if the patient is opting for a non-surgical option, then you can do a collagenase injection or needle aponeurotomy. AMC exam tip for Dupuytren contracture is there has to be an elderly male with a thick cord-like structure in the palm, and finger flexion would be there. They can also provide a picture for it, or they could also describe the picture to you in the exam stem. That wraps up today's high-yield topics from orthopedics and rheumatology. If this video helped you, don't forget to like and subscribe and share it with others preparing for AMC Part 1. You can comment below the topics that you want me to cover, and new videos I'll drop twice a week. So I want you to stay consistent and keep following the playlists, and let's crack AMC together, one smart step at a time. Thanks for watching. See you in the next one.